أهلا بيكم. Today we're going to finish what we started, the oral cavity. Last time we studied the roof and the walls and part of the floor of the oral cavity. Today we will finish this. Of course, a major part of the floor is the tongue. It's a muscular organ, freely mobile, and rests on the floor of the oral cavity. It has an anterior or so-called oral part and a posterior pharyngeal part. Now the oral part is horizontal while the pharyngeal part is vertical. Remember this, it forms the wall of the oropharynx, anterior wall of the oropharynx. It's like hidden back. Separates the two parts V-shaped sulcus called the sulcus terminalis, and at the apex of this sulcus we'll find a foramen called the foramen cecum. This foramen is due to the epithelial invagination to form the thyroid. Remember when we studied the thyroid, we said it has a connection with the base of the tongue through the thyroglossal ligament that was a duct before. So it's normal to find thyroid tissue below the tongue along the tract of the thyroglossal ligament. Remember, the anterior part is the anterior 2/3 and the posterior part is the posterior 1/3. Now this is the apex of the tongue, and the part we'll see of the geniohyoid is the root of the tongue, the part that is that attaches to the hyoid bone too. Papillae, the tongue surface is rough to have better handling of food. We have four types of papillae. Filiform papillae, that's all over the tongue. Of course, we are talking about the anterior 2/3, and no papillae on the posterior 1/3. We have four types. The filiform papillae, finger-like projections on the surface of the tongue. We have foliate papillae, the linear mucosal folds at the side of the tongue. We have fungiform papillae. It's like it's shaped like a fungus, but it's level with the surface of the tongue, so it's buried in the surface of the tongue. It doesn't project up above the surface. Fungiform papillae. It's more prominent at the sides. It's all over, you can find here, but it's more prominent at the sides. And last we have big papillae called the valate papillae or circumvallate papillae. They are between 8 to 12 and present on a V-shaped line right in front of the sulcus terminalis, not at the sulcus itself, right in front of it. Now, papillae carry taste buds in them, except the filiform. Filiform has no taste buds. Taste buds are usually present at the sides of papillae, in the cleft formed between the papilla and the surface of the tongue. It's a chemical receptor to detect the taste of food. So remember the four types of papillae, please. This is a good area for MCQ questions. The inferior surface of the tongue is smooth, covered by mucosa, of course. It shows three folds. The median fold called the frenulum. The frenulum of the tongue, if you remove it, you will find the base of the intermuscular septum, longitudinal midline septum in the tongue that divides the tongue into right and left sides. It covers it from beneath. And we have a couple of fimbriate folds at the sides of the inferior surface of the tongue. Don't confuse this fold as part of the inferior surface. It's on the floor of the mouth. It's produced by it's called the sublingual fold. It's produced by the sublingual gland. Don't confuse this with the other folds. Of course, no papilla on this surface. It's all mucosal folds. Now, the muscles of the tongue, they are classified into extrinsic and intrinsic muscles. Means that extrinsic is muscles are muscles that originate from outside the tongue, other area than the tongue, and inserts into the tongue. But the intrinsic muscles originate and insert inside within the substance. They form actually the substance of the tongue. Okay? They are free, not attached to bone. There's a median sagittal septum that divides the tongue into right and left sides. And all muscles are paired. And if we started with the intrinsic muscles, it's thrown into 4 groups according to direction. There is vertical group, horizontal group, or transverse group. There are longitudinal groups taking the length of the tongue, like the superior longitudinal and the inferior longitudinal groups. This is, of course, a cut section. So you'll see a cut section of them. It makes sure that one can move the tongue in every direction. Also, they alter the shape of the tongue. Between curling, uncurling, flattening and rounding, shortening and lengthening, and when they act in harmony in pairs, you can get very precise movements of the tongue. By the way, they call the tongue the policeman of the oral cavity. You all notice that anything foreign inside the oral cavity, maybe an injured gingiva, slightly broken tooth, a fish bone between teeth, the tongue always go there and always detect it's like palpating the odd structure that's present inside the oral cavity. They call him the policeman of the oral cavity. Don't forget that it's very sensitive. The extrinsic muscles, see, the genioglossus, although it's a major form of substance of the tongue, it's not intrinsic because it's attached to bone. Where it's, remember the mental spines, we said the inferior mental spine attaches to geniohyoid, the superior mental spines attaches to genioglossus. It's at inside of the anterior end of the mandible. And it's fan-shaped, it fans, see? Now, the very posterior inferior parts attached to the hyoid bone, this is the root of the tongue we were talking about. This is the root of the tongue, okay? The genioglossus is part of the one of 4 muscles that's classified as extrinsic: styloglossus, palatoglossus, genioglossus, and hyoglossus. The genioglossus, we said, it forms the bulk, and the action is that it depresses the center of the tongue and protrudes the anterior end of the tongue outside of the oral fissure. Oral fissure means mouth, the fissure between the lips. So protrusion of the tongue. Now this movement, protrusion of the tongue, we use as a test for hypoglossal nerve, because hypoglossal nerve is the motor nerve of the tongue, except one muscle. But now, please understand this. The right genioglossus protrudes the tongue anteriorly and to the left. The right genioglossus protrudes the tongue anterior and to the left, while the left genioglossus protrudes the tongue anterior and to the right. When both of them work together, the tongue will be protruded in the midline, in the middle, because the right and left deviation will cancel each other, right? Okay. Now a case of hypoglossal nerve injury. Someone stabbed in the neck, for example. Neck. Why the neck? Remember the hypoglossal nerve? We studied it in the neck as the most superficial part in the carotid triangle. So it's easily injured. What happens if you ask this patient to protrude the tongue? If the left hypoglossal, for example, now the left hypoglossal means the left genioglossus. The left genioglossus will not be able to protrude the tongue and to the right. So the right genioglossus will operate on the tongue. So the tongue will be protruded forward and to the left, not opposed by the left one. Okay, so we have a left hypoglossal nerve lesion and the left deviation of the tongue. So they say that the tongue always points at the side of injury. Remember this, because we always, in nerve injuries, we see that, like in facial, Bell's palsy, for example, if the right facial is paralyzed, the face is taken to the left side. See, but here with the hypoglossal test, protrusion of the tongue, stick out your tongue test, if the left hypoglossal is injured, the tongue will be protruded and to the left. It will point to the injury. Please remember this, and this is also a good area for multiple choice questions. Another muscle, extrinsic muscle, is the hyoglossus. Of course, we know about the hyoglossus now. It's a quadrangular muscle that originates from the greater cornea or horn of the hyoid bone, ascends upwards and vertically to insert in the tongue. And the hyoglossus is a key muscle for relations. It's a very good area for multiple choice. I'm sorry that I'm stressing on each point, but actually the lectures we are studying, I'm studying with you, are all concise I tried my best to make it as a good source for multiple choice question answers. Okay, this is what's important now. We want to pass exams. Of course, we want to understand the part, but we want to pass exams. So please concentrate in this. We were talking about the hyoglossus. It's a key muscle. Remember what's on the lateral side, lateral surface of the glossus muscles? The two nerves, right? The lingual nerve with the submandibular ganglion hanging from it, and the hypoglossal nerve with the venae comitatus or the deep lingual vein beneath it, right? Remember this. Actually, they go with the hyoglossus to the oral cavity. Now, what's on the medial side? We have the lingual vessels. So remember, the lingual vessels medial and the lingual nerve lateral. This is a very important muscle. Of course, it depresses the tongue, the hyoglossus, for its the way it's originated and inserted. It depresses the tongue. This is another muscle, one of the extrinsic muscles, the styloglossus. The styloglossus originates from the lower anterior end of the styloid process and descends through the oropharyngeal aperture and inserts in the upper border of the hyoglossus and the intrinsic muscles of the tongue. Of course, by its direction, it raises the posterior end of the tongue. And you expect that when you are trying to close the oropharyngeal isthmus, like, for example, breathing while eating. Okay, palatoglossus muscle. It's one of the palate muscles, and so because it's one of the palate muscles, so you expect that this is the one that's different in nerve supply than the other tongue muscles. It's supplied by the pharyngeal plexus, the vagus. Remember that. It comes from the inferior surface of the soft palate and inserts into the sides of the tongue. Of course, the palatoglossus, with its direction, the way it originates and inserts, it raises the sides of the tongue. But the important function of this muscle, that it depresses the soft palate while raising the posterior surface of the posterior part of the tongue, and approximating the two folds towards the midline, the palatoglossal folds. This means that you are closing the oropharyngeal isthmus, as we mentioned before. Okay, the blood supply, arterial and venous drainage. Arterial supply, of course, from the lingual artery. Now, the lingual artery, we studied this as the second branch arising from the anterior surface of the external carotid artery. Remember, the superior thyroid, lingual, then facial. Now, the mark for the origin of the lingual is the tip of the greater horn of the hyoid bone. And once it arises, it forms a loop, upward loop, and then down again. Why does it do that? Remember the loop of the inferior thyroid. Why did it make a loop? To give a slack for the movements of the tongue. Remember, the lingual artery is going to supply a highly movable organ. So it must have a slack in it. لازم يبقى فيه طول زيادة علشان ما يتقطعش مع حركة الtongue, so as not to get torn with the movements of the tongue. And after forming the loop, it disappears medial to hyoglossus and goes along the surface, medial surface of the hyoglossus, between the hyoglossus and the genioglossus, means between the hyoglossus and the tongue itself, and supplies the tongue and the floor of the mouth and the lingual surface of gingiva, the inside surface of the gingiva of the lower jaw. Now it gives branches. It gives a dorsal branch. It continues in the middle and gives a deep or sublingual branch that supplies the undersurface of the tongue, or the lower part of the tongue. The veins, it supplies also the sublingual gland. Don't forget that. The veins follow the arteries. We have a vein that follow the dorsal branch, a vein that follows the lingual artery. It's the lingual vein, the dorsal lingual vein, and the sublingual or the deep lingual vein. Now, put in mind that these two veins, the dorsal and the lingual, remain medial to the hyoglossus. They follow the course of the lingual artery. While the sublingual or deep lingual is sometimes it's called the Ranine vein. It gets separated from the lingual artery posteriorly with the hyoglossus. See? So it becomes lateral, on the lateral surface of the hyoglossus, either in the form of venae comitatus to the hypoglossal nerve, or runs by itself below the hypoglossal nerve and eventually opens with the lingual vein in the internal jugular vein. Remember this. And this is the one that we see underneath it's visible on the sides of the frenulum of the tongue, on the surface of the tongue. Okay? Okay. The innervation comes from also the lingual nerve. Lingual nerve is a branch of the mandibular nerve, actually a branch of the posterior division of the mandibular nerve. It descends, goes on the lateral surface of the hyoglossus muscle, right, and enters the mouth or the oral cavity between the origin of the mylohyoid and the superior constrictor. Means it will be on the bony wall of the oral cavity. It will be on the lower jaw in a groove right underneath the third molar. Don't forget this important fact, that the lingual nerve grooves the bone under the third molar, and actually the dentist can palpate it with his finger at this point. Why does he have to palpate it? To avoid injuring it while injecting the anesthetic. So it's liable to injury if the dentist is operating in this area on the third molar or on the gingiva, for example, or by the anesthetic injection. So that's why he goes backwards, actually, to catch up with the inferior alveolar before it enters the mandibular foramen. He's not anesthetizing the lingual nerve, he's anesthetizing the inferior alveolar nerve. Okay, but the infiltration anesthesia reaches the lingual. That's why you lose the sensation in the tongue, and you lose the sensation along the branches of the inferior alveolar, like the mental branch that for the lower lip and the chin. The lingual nerve is joined by the chorda tympani. See that? Chorda tympani, this small branch that was arose from the facial nerve inside the ear, and it has a course inside the middle ear, and emerged from the fissure called the pterygoid fissure. Then it joined the lingual nerve, descended with it. Some of its fibers left the nerve, see this posterior filament, to form the submandibular ganglion, because it carries parasympathetic fibers from the fascia, and some rest of the fibers continued to the tongue to supply the tongue anterior 2/3 with taste sensations. Now, you know that there is anterior 2/3, posterior 1/3, separated by the sulcus terminalis. And of course, in front of the sulcus terminalis, the valate papillae that have taste buds on their sides too. Now, they leave all this in questions, and then they ask you, what's the nerve supply of the sulcus terminalis itself? What do you think its nerve supply, taken with the anterior 2/3 or the posterior 1/3? The sulcus and the valate papillae in front are taken with the glossopharyngeal nerve, the nerve of the posterior 1/3. Don't forget this. The anterior 2/3, I don't mean the sulcus with it. No, it's without the sulcus, without the valate papillae. So the chorda tympani carries taste impulses from the anterior 2/3 of tongue as well, and it carries parasympathetic to the submandibular ganglion. See how many nerves supplying the tongue so far? Okay. Now, when you talk about the course of the lingual nerve, don't forget the important relation with the duct, that it crosses the duct of the submandibular gland from lateral to medial underneath the duct. Okay, it's immediately medial to the sublingual salivary gland. Don't forget that. Okay, another nerve, the facial nerve. Of course, it supplies the tongue because we mentioned the chorda tympani. So that's another nerve, lingual and facial. That's two nerves. The glossopharyngeal nerve, the ninth cranial nerve, it descends from the jugular foramen. Remember the jugular foramen that transmitted the internal jugular vein and the lower and the 9th, 10th, 11th cranial nerves. This one descended from the jugular foramen along the posterior surface of the stylopharyngeus, and lower down it crosses the stylopharyngeus from lateral to medial to enter the oropharyngeal aperture and end in supplying the soft palate and posterior 1/3 of the tongue. Now, the glossopharyngeal nerve supplies or carries general somatic afferents, that's general sensation. Like we said with the lingual, it carries general sensation from the anterior 2/3 plus the taste. And glossopharyngeal carries from the posterior 1/3, including the valate papillae, carries taste from them and general sensation from the posterior 1/3 as well. Okay. The last nerve, that's three nerves now. The last nerve is the fourth nerve, is the hypoglossal nerve, number 12, cranial nerve number 12. Remember, the hypoglossal nerve descends from its own canal near the occipital condyles and the foramen magnum of the skull, descends on the internal carotid, remember that, and then turns anterior, looping around a branch from the occipital artery to the sternocleidomastoid, and crosses, while going anteriorly, it crosses the internal external carotid, then the lingual artery, and goes on the lateral surface of the hyoglossus towards the tongue to supply the muscles of the tongue. Now, I didn't point out structures in these two specimens. Why? I want you to figure out which one is showing the course of the hypoglossal nerve, complete course, and the lingual nerve. See that? Here, this is the hypoglossal nerve, but it's cut. This is the lingual artery. Now, here's the lingual artery. This is the hypoglossal nerve, and this is the lingual nerve. How did I know that? Well, the lingual artery is not visible here, so it's covered by the hyoglossus. The lingual artery is medial to the hyoglossus, so these structures should be lateral to hyoglossus. This is how you identify structures. And there are two nerves there, and you know the lingual is superior to the hypoglossal. So this is the lingual and this is the hypoglossal. While here, the hyoglossus is still in place, by the way. This is the, the hyoglossus is removed. So this is structures deep to the hyoglossus, which are the lingual vessels. So apparent here. See how to identify structures in practical anatomy? Don't forget that. And don't forget the relation with the hyoglossus. It's a key muscle. Lymphatics, eventually, of course, to the deep cervical lymph nodes. But remember that the posterior part drains directly to the jugulodigastric part of deep cervical lymph nodes. And the anterior parts of the tongue may go directly to the deep cervical lymph nodes or indirectly through submental and submandibular lymph nodes. Don't forget that, especially the front, the apex, and the sides of the tongue. Why is it important to know the lymphatic drainage? Because, and I attended that, and it wasn't a good experience actually, hemiglossectomy. If there's a cancer tongue, if there's a cancer in any organ, you must remove the organ and the draining lymphatics, because if you removed only the organ and left the lymphatics with all the metastases in it, metastasis means the messengers of the malignant tumor through lymphatics or through blood vessels or through even direct infiltration. So the lymph receives metastases, cancer cells. If you left them there, they will regrow, continue their growth, and you, as if you did nothing. You just remove the organ and left the cancer to regrow. Okay? So what do you expect would happen with this hemiglossectomy? Well, the patient removed half the tongue, half the floor of the mouth, and all the soft tissue other than vessels on the same side of the neck. It was a very painful operation. It's called block neck dissection. It's not a nice thing to see. Okay, salivary glands, all salivary glands. We said that the major salivary glands are parotid, submandibular, and sublingual, and there are many scattered salivary glands all over the oral cavity and the palate, and the wall of the pharynx, wall of the oropharynx especially. So we studied the submandibular. Now it's turn of the sublingual. Sublingual occupies the lingual fossa on the mandible. Remember the submandibular fossa for the submandibular gland. This is the lingual fossa for the sublingual gland on the inner surface of the mandible. It's almond shaped. A superior border pushes the mucosa of the oral mucosa of the floor of the oral cavity to raise them into the transverse sublingual fold. Remember that? Transverse, or the sublingual fold. And the gland itself opens by numerous ducts or ductules, see those, in this transverse fold. Actually, the anterior part of the gland may join the submandibular duct to open into the papillae. But if you are asked about the way the gland opens, it opens by numerous ductules or ducts in the floor of the mouth, raising at the transverse sublingual fold, raised by the gland itself. The gland itself is immediately lateral to the duct and the duct of the submandibular gland and the lingual nerve. Don't forget this relation too. Okay. The parasympathetic supply for this gland comes through the chorda tympani, through the lingual nerve, submandibular ganglion. Some of the filaments leave the ganglion and accompany the lingual nerve till it supplies the sublingual gland. Now, remember the rule. All glands, salivary glands, above the level of the oral fissure are supplied parasympathetic by the facial nerve of the greater petrosal part, while below the oral fissure by the chorda tympani branch. Now, this does not include the side gland, which is the parotid. The parotid is supplied parasympathetic by the ninth, by the glossopharyngeal nerve. We will study this in the face and parotid. Some definitions. The oral fissure is the fissure between the lips. The lips themselves contain the orbicularis oris muscle, contains the lymphatics and vessels that supply the lip, okay, branches of facial. The lip margin, see, this is called the vermilion. It marks the transition zone between the oral mucosa, covers the inside of the lip, and the skin outside of the lip. If you see it in histology, you will see a transition zone between both areas. We have philtrum. Philtrum is the midline ridge between the nose and the upper lip. The median labial frenulum, these mucosal folds, see that? That connect the lips to the mucosa covering the gingiva. Okay. And last we have the oropharyngeal isthmus. Again, it's boundaried superiorly by the hard palate, on the sides by the palatoglossal folds, and the floor is by the sulcus terminalis. This is the oropharyngeal isthmus. It's the connection between the oral cavity and the oropharynx. And of course, you know, if you close this oropharyngeal isthmus, you will be able to breathe while eating, for example. Yes. Or holding liquid inside your mouth. Okay, we are done with the soft part. Let's go to the hard part, which is the teeth. Now, you all know the gingiva, lefa. It's a specialized part of the oral cavity that surrounds the teeth and covers the alveolar process, alveolar margin of the jaws, the margin that has the sockets in it, alveolar sockets that accommodates the teeth. The teeth are, where we will talk about adult teeth now. There are 32 in number, 16 in each jaw, 8 in each quadrant. They consist of 2 incisors, 1 canine, 2 premolars, and 3 molars. Now, in human beings, they have two sets of teeth: the decidual teeth and the adult teeth. Decidual, baby teeth, الأسنان اللبنية, baby teeth. They are less in number because the jaw is smaller in size and length. They have two incisors, one canine, and two molars. That's it. So if you count this, 5 in each quadrant means 20 teeth. They have 20 teeth. Now, the two molars will turn to be or will become the premolars of the adult, while the posterior part of the jaw grows and gives space for the additional 3 molars on each side. You got that? So we have 20, but the jaw was at the same size of the 20, accommodates only the 20. While the kid is growing, his jaw is elongating backwards to allow space for the extra 3 teeth, which are the molar teeth. So remember, the molar teeth, they weren't any baby teeth, baby molar teeth. No. They just came out once and it's an adult tooth. But the rest of the teeth were all baby teeth and were replaced before by the adult teeth. Okay? Okay. For each tooth, it has an upper part called the crown, which is made up of translucent enamel. It has a central core, which is the dentin. See all this orange stuff? Dentin. It has roots. These roots. Now the roots meet the crown at the cervical margin. This cervical margin, or the neck of the tooth, cervical margin. As we said, the dentin fills up a major part of the tooth, and it has a central pulp within it. We'll talk about that. Observe that the pulp connects inferiorly through a pulp canal and a pulp foramen with this membrane, which is the periodontal membrane. Okay, it's continuous with the periodontal ligament or membrane. Okay, each tooth is covered by, see this thin blue layer? It's a cementum. It's bony-like material that sticks the roots to the periodontal ligament. Okay, so it fixes the tooth. Okay, so you have learned about the pulp canal, and etc. Okay, now the animal is, we said it's translucent hard material, formed 99% of crystalline apatites. And this crystalline apatite molecules take the form of prisms or rods if you look at it under the microscope. The dentin is a hard but resilient or compliant material, like shock absorbing material, but it's hard material. Fills up almost all of the tooth. Okay, it's formed by cells called odontoblasts. Odontoblasts are present in this area. See this dark area at the pulp. Odontoblasts. Actually, the odontoblasts form the dentin while they regress to the pulp, leaving these tubules. See, the tubules in the dentin contain the processes of the odontoblasts present at the pulp. Don't forget that. So it's formed by odontoblasts, and it's formed slowly throughout life. Okay, the dental pulp is an area of soft connective tissue that carries the nerve supply and the blood supply of the tooth and nutrition for the odontoblasts present in the margins of the pulp. And remember that the pulp connects through the pulp canal to the periodontal membrane. Cementum is a bony-like material, cover the dental roots, and it's perforated by, see, these fibers, transverse fibers. They are called Sharpie's fibers. They are bundles of collagen fibers to allow more fixation of the tooth to the surrounding structures, called Sharpie's fibers. They invaginate the bone too. Okay? Don't forget that. The cementum. The periodontal ligament is also traversed by the Sharpie's fibers. Now, this ligament is vital because it stimulates or encourages the growth of tooth. Okay? And it's sensitive. It changes its thickness according to the way the person is chewing his food. It's sensitive to the position and forces applied to the tooth. Why? To provide the brain, the brainstem centers, with sensory impulses about the condition of the chewing status. What are you chewing? A solid material or a soft material? Remember, if you have a nut, if you're trying to break a nut with your teeth, you will apply exactly the amount of force needed to break this nut, not more and not less. And if you try to chew a piece of bread, for example, the force, of course, will not be like the one you use to break the nut. All this because the teeth are sensitive, because of the periodontal ligament that sends continuous sensory information about the forces applied to the tooth to determine the amount of force to apply between the jaws. It's a very sensitive, but we don't feel it. Actually, it happens involuntarily. Of course, the alveolar socket, we talked about it. It's the one that accommodates the tooth itself. Now, the periodontal ligament in histology contains osteoblast that builds bone, osteoclast that destroys bone, cementoblast that deposits cement, and odontoclasts that eat up the cement. I told you, the membrane varies in size through life. Okay, vessels. Now we're talking about the blood supply of teeth. So expect to hear the alveolar word, alveolar artery, inferior alveolar artery, superior alveolar arteries. Okay? So alveolar means supplies the teeth. Inferior alveolar artery, it's a branch of the maxillary artery, and luckily for us, it follows the course of the inferior alveolar nerve. They have the same course. It goes through the mandibular canal, so it passes between, we will talk about this later in details, passes between the medial pterygoid and ramus of mandible, enters the mandibular foramen, remember the mandibular foramen, into the mandibular canal, supplying the teeth. At level, goes anterior as it reaches the level of the first premolar. It divides inside the canal into incisive branch and mental branch. Now the mental branch will continue and goes outside the bone through the mental foramen to supply the cheek and the lower lip, while the incisive artery will remain in the canal to supply the rest of the teeth. Okay? Remember this, it stays up to the level of the first premolar, and then it divides. The superior alveolar, actually it's superior alveolars, anterior and posterior superior alveolar arteries. They all originate from the maxillary artery. The posterior superior alveolar originates from the maxillary in the pterygopalatine fossa and exits the fossa through the pterygomaxillary fissure. And at the back of the maxilla, it gives many branches that perforate the maxilla, and you can see them actually in the maxilla. The posterior superior alveolar will supply the molars and the premolars. The anterior superior alveolar, now this comes from a branch that is a branch of the maxillary. It comes from the inferior alveolar artery. Infraorbital artery, that's a branch of the maxillary in the orbit. This infraorbital artery grooves the floor of the orbit and then sinks down in a canal that opens at the front of the face to supply the cheek area and the lower eyelid and the lateral side of the nose. It's the infraorbital. While in the bone, it gives the anterior superior alveolar to supply the rest of the teeth. In this example, the incisors and the canine teeth. Got that? It's very simple. Inferior alveolar from the maxillary artery. The superior alveolar from the maxillary artery as well, but from a branch of the maxillary artery also added. It's the infraorbital. Okay? The gingival supply, to be honest with you, I was never asked about gingival supply, but I have to say this because I must deliver the almost complete information, concise, complete information about the subject. The gingiva has two surfaces. An outer surface that faces the vestibule of the mouth. You know the vestibule of the mouth now, or the lips and cheeks. It's called the vestibular surface. Okay, or the buccal surface. So if they're talking buccal or vestibular surface, they mean the outer surface. The inner surface that faces the palate or faces the tongue, it's called the lingual or palatal surface. Okay, buccal surface of the lower teeth is supplied by the inferior alveolar, while the palatal side is supplied by the lingual artery. It's logic, it makes sense. The buccal gingiva of the upper teeth is supplied by the anterior and posterior superior alveolars. The same rule. The artery that supplies the tooth supplies the buccal surface. The palatal or lingual gingiva is supplied, remember, the greater palatine vessels by the greater palatine and the nasopalatine. We will study this when we get to the pterygomandibular, the pterygopalatine fossa. By the way, you may find another name for the pterygopalatine fossa. It's the sphenopalatine fossa. The veins follow the arteries and eventually into the pterygoid, venous, plexus. Some veins through the mental foramen to facial vein. Now, the pterygoid venous plexus is present between the lateral and medial pterygoids and may infiltrate the substance of the lateral pterygoid. That's why we consider the lateral pterygoid as a heart. It pumps blood. And it's put in the lateral pterygoid because the lateral pterygoid is the muscle that opens the mouth. We will study this later. So we use it more than the mouth closed. Actually, we talk too much. This is the principle of yawning, for example. We will talk about this in details when we get to it. Now, this pterygoid venous plexus is connected to a dural venous sinus. Venous sinus, they present in the intracranial, in the cranial cavity, and they are spaces lined by endothelium between the dura and bone, filled with blood. So they do not have muscular wall. So any hemorrhage from the dural venous sinus is not controllable. Got it? One of the very important sinuses is the cavernous sinus. We will, of course, study this in details. The cavernous sinus is connected through emissary veins to this pterygoid venous plexus. So any infection, tooth infection that's neglected, or maybe I'll tell you something. That's why if someone has an infection in tooth, The dentist doesn't remove it while the infection is still in progress, because he's afraid that the organisms or bacteria causing the infection may go through the emissary veins to the cavernous sinus. And by the way, the veins of the head are valveless. There are no valves, so the blood moves freely from side to side. Okay? Lymphatics to the submandibular, submental, and deep cervical lymph nodes. Now the innervation. The innervation, of course, expect alveolar, the word alveolar. We have inferior alveolar. We have posterior, middle, anterior, superior alveolars. Okay? The inferior alveolar nerve comes from the mandibular nerve. This is the third division of the trigeminal nerve, the fifth cranial nerve. The inferior alveolar descends, goes into the mandibular foramen, but after giving a small nerve, thin nerve called the nerve to mylohyoid to supply the mylohyoid. Now we studied the mylohyoid. The nerve to mylohyoid coming from the inferior alveolar before it enters the mandibular canal. Now in the mandibular canal, it supplies till the second premolar in the canal, then divides into incisive branch and mental branch. The mental branch goes out of the mental foramen to supply the chin, and the lower lip. The incisive branch remains in the canal and supplies the rest of the teeth. Okay, it's the same like the artery. But I'd like to draw your attention here to the fact that after any procedure on the lower jaw, the anesthesia infiltrates the inferior alveolar. That's why the injection goes backwards. See, to infiltrate the area, to infiltrate the inferior alveolar nerve before it goes in the canal. And the fact that after the procedure, we get numbness and lost sensations in the chin, in the lower lip, and because of the involvement of the lingual nerve as well in the infiltration anesthesia of the corresponding side of the tongue. Remember this, okay? The superior set of teeth is by the posterior, middle, anterior, superior alveolar nerves. Now the posterior superior alveolar, the same story, comes from the maxillary nerve in the pterygopalatine fossa and through the pterygomaxillary fissure, goes to the back of the maxilla, but it doesn't perforate in multiple branches, no, in one branch, goes through the maxilla, finds itself in the posterior wall of the maxillary air sinus, and in the bone it supplies the molar teeth. This is the posterior superior alveolar. But notice that this network of, or this plexus of nerves, it's formed up by the posterior, middle, and anterior branches. Okay? But the molars are supplied by the posterior, which is connected with the middle through the plexus. The middle comes from the infraorbital nerve now, that inside the orbit, but still in the groove, didn't sink in the canal, supplies the premolar teeth. Okay? And as the nerve continues in the canal, and all this, of course, in the medial, in the walls of the maxillary sinus, it sends a branch to supply the rest of the teeth, like the incisors and the canine teeth. Okay? And all connected to a plexus. Remember, the nerve that comes out of the infraorbital in groove is the middle. That comes out of the infraorbital in canal is the anterior. Okay? It's logic. The nerve was still outside the canal and then sunk into the canal. See? See? This is the canal. See? This is the canal. Okay. Now, innervation of the gingiva, the last part. The buccal side of the upper teeth, like the teeth we said, with the anterior, middle, and posterior superior alveolar nerves. The buccal side, which is the vestibular side. The outer surface, outer side. The inner side, the palatal side of the upper teeth, is by the nasopalatine and greater palatine. The same story of the arteries. The nasopalatine, of course, it's more anterior, so it supplies the gingiva of the incisor and canine teeth, while the greater palatine supplies the rest of the teeth, remaining teeth. The buccal side of the gingiva of the lower incisors and canine and premolar, lower teeth now, supplied by the mental branch of inferior alveolar. After the inferior alveolar exits the mental foramen as mental branch, the mental branch sends posterior branches to supply the gum backwards all the way till the premolars. But the buccal side of the lower molar teeth, supplied by the buccal nerve of mandibular division of trigeminal. We will study the buccal nerve when we get to the infratemporal fossa to study. It's a sensory nerve. Don't confuse that with the buccal branch of facial nerve. This other branch is motor. The palatal or lingual side of all the lower teeth are supplied by the lingual nerve. I know it's a tough subject, but I hope you got the maximum benefit from this lecture. Thank you very much for watching.